Good afternoon, everyone. My topic of video presentation is measure cataract bailing out. This is a measure cataract. Patient was 85 years. I operated her almost 2 years back. And this is very common.
Sorry to interrupt you, sir. Your audio is not clear.
Okay. So this idea most usually is to make a image size cataract. There are several techniques described for the same. However, I do believe that double laces technique is very useful and practical in almost all cases. Yeah, initially we have to make a small cataract. And after that, we can speed up the material
Dr. Deka, you can try, you put off your own video to, keep it off. You keep it unmute and run the video.
So switch off your video. Sir, your mic is on mute. Please unmute yourself.
Is it okay now?
No, just put off the video. Video off for you.
Switch off the video, sir. Then your bandwidth is.
No. Your Amarendra, your picture, Dr. Deka, your picture, your own video, not the screen the video. Yes.
So continue.
I think he lost the connection.
So maybe I think.
So
Yeah, it's okay, I think.
Okay.
Yeah. Again, present the case. Share the presentation again.
So this is a 81-year-old lady with major cataract. I operated years back. This type of cataract is very common in our day-to-day practice. But these cases are very difficult to handle because there may be complications at any stage of implementation. Here, most and foremost, there is the complete cataract stage. Complex study is important. There are several cataracts. Here we should make a small cataract stage initially. After that, we need to squeeze out the liquid lens matter so that intraocular pressure reduces. After that, we need to make a small ring and enlarge the cataract stage as is here. And this is very predictable technique, and you can achieve round center details in almost all your cases. Next step is hydro procedure. Here we should do minimal hydro procedure because if you aggressive hydro procedure, there may be bulging of the capsule and arterial interruption. Next is specific technique. Here, ideal technique is shopping technique. In this case, I tried horizontal shopping. Here, it is very important to protect posterior capsule as there is no clear hole behind protecting the posterior capsule. What is judicious use of this is very important. However, I skipped that step due to paucity of time. And this is required not only to protect the posterior capsule as well as to protect the endothelium because as there is no protection behind, we have to specify some pieces of nucleus at iris plane or even with the endocapsular bed anterior circumference. So far, everything looks very fine. Operation is very uneventful, but now next step is aspirating out the remaining cortical matter. Here we need to observe minutely. So during this phase, you can see there are some wrinkling on posterior capsule. This is very alarming and is indicative of jonular dehiscence. So now we have two options. One option is to put the lens, and second option is put the endocapsular ring and complete the surgery. And I decided to put endocapsular ring as I plan to implant single piece monofocal lens. So this plastic is injected. Now endocapsular ring is also implanted. And now we can see very stable capsular way. And next thing is to implant the lens. Recently, this patient has come for check-up after 2 years, and the lens is still stable. So, what is the take-home message? Take-home message is if we have any complication during intraoperative period, we should try to handle it during intraoperative period only to avoid complications and surprises post-operatively. Thank you so much.
Thank you, Dr. Amarendra. Your video was fantastic, but the audio snatches has taken away a lot of problems, has invited. But keeping cool and strong nerve at the height of crisis, you have shown. Thank you so much.
Thank you, sir.
Next, we have Dr. Manas Nath, who will be showing us pearls for managing decentered IOL. Over to Dr. Manas.
Yes, sir. Thank you, sir. So I'll start sharing my screen. Is my screen visible, sir? The slides?
Yes.
Dr. Manas, switch on your video.
No, actually, I want to keep it in off mode to have a good internal.
Continue. No problem.
Okay, sir. Okay, no problem.
So I'll be talking about management of descended IOL. So we can see this descended IOL either intraoperatively in the early postoperative period, and sometimes we can see in late period as well. So let's coming to the first scenario. This is a young patient with lenticular glaucoma with high myopia. The IOL power was around 7 diopter. My plan was to do a phacoemulsification and placing a single piece foldable lens within the capsular bag and stabilizing the bag with one CTR and a CTS. So after doing phacoemulsification, when I was placing the single piece lens in the bag, one of my iris hook was too tight, as you can see here. And while dialing the IOL inside the bag, that part of the rhexis margin got torn. And gradually it led to a very large posterior capsular rant. So I was in a situation where nobody would like to be. But the next point was going in my mind was, how do I handle this case? I did not have the backup of a multi-piece lens. So I thought of fixing the same single piece lens either to the iris or to the sclera. But suturing a single piece lens to the iris can lead to iris shaping and pigment release. Literature has shown a good result with suturing it to the sclera. So I decided to proceed with the scleral suturing. For that, I am making two partial thickness scleral flaps exactly opposite to each other. Then a 9-0 Prolene suture, a straight needle on a 9-0 Prolene suture is inserted into antechamber opposite side port, and a 26 gauge needle is inserted from a distance of 2 mm from the limbus into the sulcus below the haptic, and the straight needle will be docked inside and will be taken out. Similarly, another straight needle will be taken out, this time above the haptic, as close to the optic haptic junction to form a loop. And similarly, the other haptic will also be sutured in a similar manner. And at the end, we'll see that the lens is well centered. Even at the post-op day 7, you can see that the IOL is well centered. There is hardly any tilt. So next scenario where the surgeon encountered a large PCR intraoperatively and placed a multiple lens in the sulcus. But next day, you can see that the lens is grossly decentered. So I took up the case for centering the IOL, and I'll suture the lens to the iris by McCannell technique, as the adequate sulcus support was not there. So after forming the anterior chamber, which is scholastic, the IOL is centered with the help of 2 instruments. Once it is centered, the optic will be captured with the help of a spatula. You can see that the optic will be above the iris and the haptic is below, and both the haptics will be sutured with your 90 proline suture, one after another. And at the end, you will see that the IOL is well centered with round pupil. So to have a round pupil, the location of the suture bite should be mid-periphery. We should take a short suture bite and avoid excessive tightening of the knots. This is my last case. This patient presented very late, almost 3 years from the primary surgery. Here you can see that the CTR back complex and the lens is decentered in the opposite direction. So I decided to fix the whole complex, that is IOL and the CTR complex, to the sclera. So that I'm passing a straight 20 gauge needle, this time under the Hoffman pocket, and the straight needle will be docked below the haptic, taking your CTR as well, one below and one above to form a loop. Similarly, the other part will also be taken away with the same manner, one below and one above to form a loop, and then the suture will be sutured under the Hoffman pocket. So then you can see that the IOL is well centered. So for to avoid tilt in these cases, the fixation points should be exactly opposite to each other, and one should have confidence in patients, because these kind of cases can take longer time than usual. Thank you.
Thank you, Dr. Manas. All complex made simple. It was mind-boggling.
Thank you, sir.
Next, I invite Dr. Amit Raj. He will show a video on large subluxation with double CTR.
Thank you, sir. At the outset, I am thankful to Suraj Bhattacharya sir and RC Kaur sir for making me part of this IC. So I am sharing a case of traumatic cataract with inferior subluxation, 4 clock hours of subluxation. Let us see how I manage this case. On table, it was not 4 o'clock hour, it was around 7 o'clock hour, from 3 to 7 o'clock, 3 to 10 o'clock hour of subluxation. So I started capsulexis. In these cases, one should perform capsulexis with forceps, and grasping and re-grasping is the key for successful completion. So as cataract gentle hydrodissection was done, in these cases one should avoid nuclear rotation. As cataract was grossly subluxated, so CTR was injected. And phaco was started. So at this point, again, bag was very unstable. So I thought, why not I put another CTR from opposite side. The idea was to give equitable centrifugal force on the bag. So after implanting second CTR, now bag was comparatively stable. As patient was young, so nucleus removal was not difficult. As they are removal of cortex was a little tricky, but it was successfully removed by contraction. A 3-piece IOL was implanted. After that, residual viscoelastic was removed.